All right. So this shouldn't take us too long. We should get done a little early today, I hope. So Parkinson's disease. All right. So Parkinsonism is kind of a general term for Parkinson's disease-like movement. So tremors, rigidity, bradykinesia, postural instability are kind of the standard things that people associate with it. And PD just happens to be a manifestation of the disease that's really focused on this. You can get it from drug reactions, specifically antipsychotics cause it. That's probably the biggest other instance where you see it. You can have Parkinson's manifestations like post-stroke or post-spinal cord injury, of course. But that's, of course, different, not the same disease. So when we're specifically talking about PD, it's not really a known cause for what actually is occurring here. There's some neurochemical abnormalities that are studied, so loss or destruction of dopamine neurons is thought to be the primary pathophysiology. But why that actually happens, we don't really know. There's been some postulations on toxins, so environmental drugs of abuse has been studied. Nothing's really shown promise as far as, okay, we know that every meth user gets PD. Well, we don't. That just doesn't happen. So we don't really understand. High body weight, milk consumption, and head trauma are all thought to be things correlated with it. So that doesn't, again, tell us really anything useful. They're just kind of interesting correlations. Age, over 60, people have double the risk. So 2 to 4% over 60 versus 1 to 2% under 60. A European study looked at 1.6% over 65 and actually 3.5% over 85. So even took that a little step further and saw it was higher once your age advanced significantly. And it's more common in men than women. Okay, so you're looking at a loss of dopamine-producing cells within the substantia nigra, which is a part of the brain that's isolated. It's illustrated here. And that's thought to be, again, the major pathophysiology. So a big treatment of Parkinson's disease is replacing this and trying to augment this loss of dopamine. Okay, so what is Parkinson's? You have a number of facts here that are kind of interesting. The Michael J. Fox Foundation, if you didn't know Michael J. Fox has Parkinson's, he does. I'm going to show you a video. Pleasurable response helping with some Parkinson's symptoms. So things that you might think about as promoting some sort of a natural dopamine pathway in the brain. So for him, ice skating is an example. Actually, they've shown that people with smoke, because of the dopamine reward system they're constantly stimulating, have a bit lower of a risk overall of Parkinson's disease than other people. So one of the only good things is smoking, I should probably say. I put this link to the New York Times Patient Voices. This is interesting. If you ever have free time and are interested to hear some patient perspectives, if you're like, what's it like to live with that disease? They're really good. They're audio clips of people, and I'm going to play some for you during schizophrenia. I'm not going to play these specifically, but if you're interested, they have a ton of them, from anything from diabetes to, again, mental illness. So I think it's kind of a good perspective in case you're like, I don't know what it's like to have that disease, or you're working with patients with that disease and want to know how that works. So anyway, protective factors, again, smoking, possibly nicotine, possibly has a neuroprotective effect, but it's also that reward-seeking behavior, possibly. Parkinson's disease patients actually have a lower prevalence of cancer, all cancer types, interestingly enough. Again, correlations that don't, again, kind of interesting factoids of this. We don't really have a lot of substantial evidence to say one way or another. Coffee and caffeine intake, higher amounts seem to be associated with lower risk of Parkinson's disease. So you guys are probably all like, great. Physical activity, so reduced activity may be a preclinical sign of Parkinson's disease. So if you have somebody who's really physically active, and then all of a sudden they kind of stop, that can be a sign. And conversely, the physical activity can help manage the symptoms and actually can be protective too. Ibuprofen actually has been looked at and correlated in some studies to be associated with a protective factor, but maybe not. And the interesting thing in the end of that video when they're talking about stem cell research and the political side of things, which I don't really want to get into, but there isn't a lot of good treatment for Parkinson's disease. We don't really have anything that protects people from it. We don't have anything that reverses it, and our symptom management is worse is mediocre at best, I would say. It's just not great. So we'll get into some of the drugs here in a second. This is just a drawing. So you guys don't need to see that. It's not important. All right. Sometimes the things I put in my lectures, like, why did I put that in there? All right. So we have some broad options, both pharmacologically and surgically potentially. So pharmacologically, again, from a neuroprotective standpoint, got a bunch of bullet points here, but everything's very theoretical. There hasn't been anything that's come across as saying, okay, we know for a fact that this is neuroprotective. However, some of the drugs we're going to talk about, like MAO-B inhibitors and dopamine agonists, which we'll get to in a second, possibly are more neuroprotective than a bigger standard therapy, which is called Cinemate. And again, all this stuff will become clear as we get into it. Some supplements have been looked at. Coenzyme Q10, vitamin E, I talked about, I think, last week a little bit. Both of them have been thought probably not helpful with respect to not really having enough robust evidence to say, yes, this is protective. And to prove neuroprotective benefits, I mean, that's a big challenge to actually do that. You have to have a long-term study with optimal doses, with limiting co-founding variables. It's very challenging. So, could some of these things be better than we actually think? Possibly, but we just don't know. And symptomatic relief is really what we're focusing on here. That's what our current therapies work with. So dopamine therapy is the oldest way we've been treating Parkinson's, and it's the most common still, and probably the most popular. It's kind of the cornerstone of Parkinson's therapy. You have a product called levodopa or L-Dopa on the market, which is a precursor to dopamine, catecholamine precursor that's physiologically it's synthesized from tyrosine. It does cross the blood-brain barrier, and then it gets metabolized into dopamine. Dopamine itself as a drug does not cross the blood-brain barrier. So like dopamine, you can give people infusions of dopamine, and it works as a cardiovascular pressor, right? It doesn't get into the central nerves. So you have to give something else, that precursor there. Carbidopa is the other form of this combination medication called Cinemate, and it does not cross the blood-brain barrier, but what it does, it inhibits peripheral metabolism of levodopa. So the problem with giving somebody levodopa is that you would get not only blood-brain barrier metabolism into dopamine, which is what you want, but you also get peripheral metabolism, which ends up triggering a lot of nausea and vomiting, and also other possibly cardiovascular related side effects. So we don't like that, and that's what this component of it does. So carbidopa really in and of itself isn't a therapeutic medication. It just helps with managing some of the symptoms. And it also helps push the more levodopa to enter the CNS. If it can't get metabolized in the periphery, it might have a better chance of actually moving into the central nervous system. Both these medications have really short half-lives, which makes dosing quite challenging. So somebody combined this medication as the drug Cinemate, and it's a combination of levodopa and carbidopa. It comes as a number of different formulations, from regular release to extended release. Even the extended release product, it's not like people are taking it once a day. They're still probably taking it 3 times a day, whereas with regular release, I've seen people taking it 5 times daily. So you can really load people up on this. There's not necessarily a ceiling dose here. And usually it's just going to be whatever people tolerate, or to the point where they just aren't getting any more benefit. You can add enough dopamine into somebody's system to the point where they just can't use it anymore, and they aren't getting any symptomatic relief with it. So that's one of the big issues with this, is that while it can work, you have that effect where you can really give somebody a lot of it, and you aren't necessarily working with the body's natural receptors as much. And we're going to talk about that a little bit with dopamine agonists, and how they might be a little bit more preferred first line over a drug like Cinemate. Again, side effects, you do get some metabolism of the levodopa within the peripheral system, so you might get some nausea, but it should be relatively well tolerated. The big problems with these are this bullet point here, especially with older patients and people who have been on Cinemate for a really long time. You're going to see psychiatric symptoms. It's just a given. It's going to happen for sure. And I'll talk about how we manage that, but it's a really big problem. That's another reason why when we talk about some of these other medications, limiting Cinemate use, especially in younger patients, is going to be key and probably recommended over starting somebody on a Cinemate regimen right off the bat. And that's mainly due to these side effects being almost inevitable. As far as stopping somebody on Cinemate, you don't want to stop somebody abruptly. You can get NMS, which is neuroleptic malignant syndrome, which is kind of like a full body rigidity. It can generate a lot of heat and can cause kind of like a septic crisis almost, not necessarily sepsis, but people get like kind of almost a full body paralysis, not a paralysis, but they get full body rigidity, all their muscles are contracting at once. So we've had this happen occasionally at our hospital. It's associated with different antipsychotics. And so with that in mind, those patients that have happened to, we've had to send them to the ICU. It's a month stay. It's fatal in some cases. So don't stop it suddenly. Just kind of gradually take somebody off of it. The dopamine free radical thing is theoretical, so I'm not going to talk any more about that. Stalevo is another brand name product that is like Cinemete's. Oh, yes, sir.
So I'm curious about cost, like the Cinemate versus just prescribing the levodopa and carbidopa separately.
I don't think it's possible to prescribe them separately. I don't think there's a product that exists. it's prescription, that's regulated. There might be L-Dopa supplements and stuff, but yeah, you probably wouldn't want to give those to somebody. I would say that, I don't know, they might have a separate, but even the generics are, it's not a brand name, it's been generic for quite a while. There might be some, I think even the extended releases are generic now, so it's relatively affordable, but they just have to take a lot of it, so it can be kind of expensive. Stalevo, I think, is still brand name. So that's basically your Cinemate backbone with this drug called entacapone stacked onto it. And its mechanism is it's a reverse catechol-methyltransferase inhibitor, which basically just alters levodopa pharmacokinetics, and you get more sustained levodopa serum levels. So you're increasing concentration available for absorption across the blood-brain barrier by inhibiting that metabolic enzyme that's working with levodopa pharmacokinetics. You make it last a little bit longer. You give a more steadied approach to it. Is this super common? Not really, but there is another drug called tocopone, which is a standalone. So you could have somebody on generic Cinemate and prescribe the tocopone as an addition, as opposed to giving them in this combination product. The problem with this is you'll see people who are on really varied Cinemate doses. So it's definitely not a one-size-fits-all. So while Stalevo in the doses it comes in may work for some patients, may be totally inappropriate for others because you just can't match what the current dose they're on. So if you want to add one of these, this one's a nice one to stack onto it because you can add it as a separate standalone drug and as a combo. However, if the doses work out, this is nice because it's less pill burden, so there's kind of a double-edged sword there. Side effects, maybe a little bit more severe. You might get a little bit more levodopa in the periphery, causing more GI-related side effects, nausea, vomiting, diarrhea. Okay, so dopamine agonists is the other, the second major class we'll talk about. So these directly stimulate dopamine receptors within the central nervous system. They're initially designed as adjunct therapy, but a lot of people argue that they don't actually promote further neuronal degeneration. So while they aren't necessarily reversing the disease, they aren't progressing it. So this is a theoretical concept, but it's thought that they might be better as a first line. And again, because of the Cinemate side effects, I tend to agree. If you could get away with one of these medications early on, a younger patient, and save Cinemate until you actually need it, or absolutely need it, that would be maybe beneficial for certain patients. Fewer motor fluctuations are shown with dopamine agonists. It seems to work pretty well. Cinemate, again, being short-acting, you have these peaks and troughs, even with the controlled releases. So while Michael J. Fox is saying in the morning it's worse, that's going to be very typical for a Parkinson's patient because their medication is going to be virtually out of their system. A lot of patients will take a big extended release dose right before bed in the hopes that it will carry through until they get into the morning. And some patients I've even seen take them, like take an evening dose, go to bed, and then wake up at 1 or 2 in the morning and take another dose. All right, you can use this in combination with Cinemate, so you can certainly combine them.
So Chad, why isn't that they have come up with a pump for this as well, so it can just kind of like titrate?
That'd be great. There's no IV version of this, so I don't know. Yeah. Yeah, if they could pump it right into the central nervous system, maybe. Yeah.
Well, I mean,
you would think that somebody's doing research on this type of stuff, but you just don't see it. And I don't know, Parkinson's might be such a rare disease, relatively speaking, that we just don't have the research dollars behind it. But yeah, and I don't know if the research is focused on more like curative efforts versus better treatment symptom managements. But yeah, I mean, we use baclofen pumps for spasticity. You'd think you could maybe come up with something, but yeah, it's a good question. All right, so the dopamine agonists are all listed here. Bromocriptine is the oldest one. It's not really used all that much anymore. Pramipexole and ropinirole are the two common ones. Mirapex and Requip are the brand names. Both of these are also used for restless legs, so you may or may not have seen them advertised heavily on TV for that reason. But this is their primary bread and butter, where they were developed for anyway. And the dosing for PD is way higher than for a restless legs indication. They are dosed frequently, but both come in an extended release formulation, so you might be able to get less frequency dosing with that. And they're pretty much equivalent. There's not really any studies that say one's better than the other, so they both work well. Ratigaltine, I think is how you say that. I don't know. Nupro is a patch that's a newer medication that came out recently that would be available. And I can't remember. It's a once daily. And I don't think it's been really trialed against these. I think it's been shown to be non-inferior to what's out there currently. So if you have somebody who's not tolerating oral, or if you have somebody who's has dementia at the same time or something like that, can't remember, has a hard time remembering to take pills, could be a better thing. But you still have to do it once daily. So it's not like it's a once weekly or every 3 days type thing. Adverse effects are pretty similar to levodopa. You don't get quite as much GI side effects if you look at like the incidence, but it's still there. You also see sedation, possibly orthostatic hypotension, and then you can get some of the confusions, hallucinations, some of the psych side effects, but it's not necessarily like it's a build-up to this psychosis like you'd see with Cinemate. It may be more like an acute thing that happens when you take the medication. So if you have somebody who trials onto a dopamine agonist and they have confusion or hallucinations, you might be able to pull them off of it or try a different one potentially. Maybe they won't have the same side effect. Whereas with Cinemate, it's an inevitability for most patients. Peripheral edema is a common one that's seen that's a bit different than Cinemate. And then behavioral issues. So you're agonizing dopamine receptors, which is messing around with your brain's reward system. So younger male patients tend to be at higher risk for compulsive-like behaviors, and they might even actually start compulsively taking extra dopamine agonists. It's been documented that this happens occasionally. So they might get, despite getting some dyskinesias and actually going beyond what it's supposed to do and causing some total lack of movement ability, they might still take more and more because they're getting some sort of a perceived high or so off of it, if you want to look at it that way. You also see some documented impulsive behaviors like hypersexuality, gambling, buying, things you'd associate with like a manic episode. It's rare, not super common, but younger male patients, it's better documented. We want to titrate slowly. If you start somebody on a really high dose, discontinuation rates are high based on these side effects. However, if you start slowly, you can adjust. The body can adjust more accordingly. Abrupt somnolence without premonition. So basically falling asleep without any real sign of it. You just all of a sudden fall asleep. That's associated with pramipexole only. It's not really associated with the other ones, interestingly enough. And it's a rare side effect, but it is something that could be potentially problematic, of course, for somebody. Withdrawal of these medications, you want to titrate off slowly, just like with Cinemate. Withdrawal is actually documented to be similar to withdrawing off of cocaine. Cocaine is not the worst medication to withdraw from. It's not from personal experience, but from a documented perspective of drugs of abuse. Okay, if we look at that, I'll give that caveat. Yeah, I have to do some cocaine before I come in and lecture. You have a lot of anxiety, panic, sweating, craving of the medication. You can't really treat it either with anything other than the dopamine agonist, so you just have to give a little bit. Again, take somebody off of it slowly. MAO-B inhibitors are similar to an older class of antidepressants called MAO-I general inhibitors. So MAO-IB is a specific subtype of this enzyme, and MAO-I, or MAO, monoamine oxidase is the enzyme, and that inhibits breakdown of a lot of different neurotransmitters. The B type is specifically more directed towards breaking down dopamine from the central nervous system. So where old antidepressants stop the breakdown of things like serotonin, dopamine, and norepinephrine, this one tends to more focus on dopamine. So you can avoid some specific side effects with it. However, these drugs tend to be kind of interesting as far as the problems that they have. So we're going to talk about MAO-I inhibitors more so during mental health and depression very briefly. They aren't used very commonly anymore. They have a lot of food issues. So there's a precursor to catecholamines called tyramine, and if you inhibit the enzyme that's resulting in that breakdown, you can end up with this tyramine backlog and upregulation, which can cause people to have sort of like a hypertensive crisis type picture going on. And there's a lot of foods that have tyramine in them too. So somebody's got one of these things blocking the metabolism of this process on board, this medication, and they eat like an aged cheese, aged wines, aged beer is another big one, aged meats. They have lots of tyramine in them. You can end up with this problem. However, with MAO-B inhibitors and Parkinson's, it's a lot less of a concern than the older antidepressants. So I just say that as a caveat. It's not really a big deal. Sledgeline's a transdermal patch, and rasagiline is a PO medication. These medications, like the dopamine agonists, are thought to maybe be protective and prevent further degradation of the current dopamine-producing neurons you have. However, we don't usually use these as monotherapy. They're usually added on to either a Cinemate dopamine agonist regimen or a one or the other as an adjunct therapy. Side effects, so sledgeline can cause confusion in the elderly. And if you're using any type of antidepressant, specifically the common serotonin ones, you can put yourself at risk for things like serotonin syndrome, which is another sort of like high temperature, hypertensive emergency type system. Super rare, but if you're going to get serotonin syndrome, it's going to be because you're on an MAO, some type of MAO drug. So it is more common with these. However, again, we're looking at the MAO-B specific ones for dopamine or for Parkinson's disease. The risk is way lower than if we look at the standard ones for as antidepressants. So just give that caveat that there's a lot of potential side effects here, but they're much better tolerated than our other medications that are in a similar class. And anticholinergics, I talk about these, a number of them here. The bottom line is this bullet point here. They are problematic because they cause anti-slut. So you get urinary retention, constipation, and people aren't going to tolerate them all that well. So they're really severely used, severely limited in Parkinson's disease, possibly for an end-stage patient who's tried everything. Or you could try it on somebody, maybe they tolerate it okay, great, but most patients aren't going to. So it's there just really for historical purposes, but it's not a common therapy at all. Then there's amantadine. Amantadine is kind of an odd antiviral that's used for Parkinson's disease. It probably has some sort of modulation on dopamine, just like everything else we're talking about, and increases neuronal dopamine reuptake potentially. It might have some NMDA receptor properties, kind of like what we were talking about with anti-epileptic drugs, but overall, and not a real common one. However, there is some theory that if you use it as monotherapy in an early mild presentation of Parkinson's disease, you might get benefit out of it there. Whereas if you wait to try and add it on when somebody's on like a high levodopa regimen and they've tried everything else, probably not going to work at all. So a lot of the school of thought behind this medication, if you're going to use it early or pretty much not at all. I mean, you could always try it, but the evidence is showing you don't get a lot of benefit when you add it on to an existing high-dose Parkinson's regimen. Okay, so first line for any patient based on kind of the current way we treat them is usually the dopamine agonist or Cinemate. You're probably going to approach it from one and based on how severe it is. So I would say, again, based on what I kind of talked about Cinemate and dopamine agonist, maybe having some more possible evidence pushing them towards being neuroprotective, you have maybe a better shot at preserving function of your existing dopamine-producing brain cells by using that first, as opposed to going straight to Cinemate. Cinemate, really think about it as purely symptomatic relief. It does a good job at that, but if we can get something else that's going to prevent, that's ideal. So dopamine agonist, first and foremost, probably in most patients. If it doesn't work, switch to Cinemate or add on Cinemate. Early mild Parkinson's disease or younger patient, I'd probably try the MAO-B first line. I know it's probably not the most, might be a bit controversial within neurologic circles, but I think based on the evidence and how they work, it's worth a shot and seeing if it works, especially if the symptoms are really mild first line. Anticholinergic probably wouldn't use. Technically, you could try it, but it's probably not going to make your patient all that happy. And then amantadine too would be something, again, we just talked about that, but you could try that in a mild case of a younger patient. So if you aren't getting adequate response from any of these things, you can start Cinemate, add your MAO-B if you haven't already done that, and you can kind of mix and match your medications that way. So there's a number of different things you can do with this, but that's generally the way you'd approach it. Yes?
Have you heard anything about like marijuana use in Parkinson's?
No.
I've seen just like.
I can't remember if that's
that could be.
Yeah, I can't remember if that's one of the approved Minnesota medical uses or not. I forget. I don't think it is, but it might be. Yeah, I haven't heard anything specifically. I know you hear these case reports, if you want to call them that, pop up here and there about somebody who tried some specific form of it and it cured them of cancer or whatever, or Parkinson's disease. I tend to be skeptical about that. Not to say there isn't validation with that. And I'll have you do some of your own research on medical marijuana. So if you want to look at Parkinson's disease as your forum post for the next block of stuff, definitely do it. All right, I think, yeah.
Is that on PO entrance?
No, it's just a patch. Yep, no PO option for that. All right, complications. We talked about daytime sedation with some of the medications, that sort of falling asleep randomly. That's a specific drug side effect. However, daytime sedation is possible, specifically with high-dose Cinemate regimens. And sleep attacks, yes, so all of a sudden you're attacked by sleep. You guys have probably been there. I've been there for sure. If somebody's struggling with this, typical stimulants, amphetamine stimulants like Adderall, Ritalin, small doses can actually be really helpful for patients. And if you we'll talk about stimulants, but they have a big stigma associated with them. But I think if you use them appropriately, they're actually quite safe, especially for a patient with this type of a situation going Hallucination, psychosis, and paranoia. Again, up to 40% of people will experience this with advanced illness. You can't really stop the Parkinson's disease regimen at this point because it's rolling. It's probably providing them some benefit. So we manage it with antipsychotics. So the two drugs that have been shown are quetiapine and clozapine. And we'll talk about these more during the mental health lecture, and you'll get more experience with them. But interestingly enough, some of the more really common antipsychotics, risperidone and olanzapine, which are two kind of gold standard antipsychotics, have been shown to actually worsen symptoms of PD. So it's kind of an interesting, we don't really know why that causes that. And then anything else somebody has, comorbidities, you're going to manage just like you would normally. But the point of this is that you can't really stop a lot of these medications because as long as you're getting some benefit, you're probably going to want to keep them going. So you really have to manage these symptoms with other medications, unfortunately.
Would you ever recommend somebody to start smoking?
If they had like a strong family history of PD, maybe. I don't know if there's a genetic component to it or not. That's an interesting question. Probably not. I would say the risks outweigh the benefits on that one, but yeah. maybe vaping, right? Yeah.
For the Cinemate, so like you said, like eventually it's like a given that they're going to get neurologic symptoms.
Yes.
Do they, like, at that point, do they generally stop?
No, you would probably, well, it depends. I mean, if their Parkinson's is totally down the tubes and they aren't getting any benefit, you might consider it. But I think at most people are going to get some benefit from a high-dose Cinemate regimen. So at that point, you're probably treating the side effect there. Okay. Yep. Keep the treatment rolling. Yep. All right, any other questions about this or anti-epileptic drugs before we call it a day? All right, good. So next week we'll have just